Starting with, what is the current capacity of the diagnostic testing system?
So as we stand today, the capacity for both NHS testing, which we call Pillar 1, and the National Testing Programme, Pillar 2, stands at 242,817 tests.
Why has that not been
per day.
Why has that not been published since the 10th of September?
That is being published at 4 o'clock today, as I understand.
Why was the gap? They were published all through the summer, but mysteriously they stopped on the 10th of September.
We have worked really hard over the last 4 months since I arrived to make sure that we validate the data that we publish. So from time to time, we are double-checking and making sure that as this organisation grows really fast and adds in new data feeds from new labs, we make sure that the data is accurate. That was the only reason for the pause.
Something went wrong that you had to put right?
No, it was simply a question of validating the data and making sure that we weren't putting data into the public domain that wasn't accurate.
It was all right.
Internally, the NHS used constrained and unconstrained capacity. Which capacity are you referring to?
This is total capacity. So if you'd like the split between the two, the NHS capacity, the Pillar 1, as of today is 82,817. That's for the UK. This is all 4 nations. And Pillar 2 is 160,000.
And they will be published every day now?
Yes.
Will they?
Yes.
Still not entirely clear why there was this period this week in which, for the first time, they were taken off without explanation.
Just simply a question of validating data. Remember how fast this is growing. So just for context, on Monday the 7th of September, the total was 226,773. So we're adding new capacity all the time. We just need to make sure that the data feeds are accurate.
During the days of this week, has the total capacity gone up or gone down?
Yes. So on Monday the 14th, it is only, I think, Wednesday today. On Monday the 14th, we stood at 231,921. So we've added 10,000 capacity in the last 2 days.
That's increasing?
Yes.
Okay. Now, so what is the current level of demand for tests?
It's quite hard to give you an accurate figure of the level of demand because, it's clearly obvious there is significantly more demand than there is capacity today. So the best way we have of estimating the total demand at the moment is the number of people calling 119 and the number of visits to the website. But that's not going to be a completely accurate, it's a proxy.
You must make an estimate, I assume.
Well, we make an estimate, but the number of people calling 119 and visiting the website would be 3 to 4 times the number of tests that we currently have available. But there will be some double counting in that. People will call from their home line and then from their mobile.
If you're managing the system, you must have a view of what the real demand is and what the capacity is. What is your estimate? Leaving aside people having to call multiple times because they can't get through, strip that out. How many people want to test? Then we'll relate that to how many tests are available.
I think, it is multiples of the total test capacity we have today. Bearing in mind the question you asked, Chair, of what is the demand, the number of symptomatic people who should be coming forward for a test will be significantly lower than that. What we have got, and we know this from surveys in our testing sites, that up to 20-25% of people who've been coming forward for a test don't have any symptoms.
When you say coming forward for a test, in order to register, you have to have symptoms, do you not? In order to be given a test place, if there were one available, you have to report one of the 3 symptoms.
We ask people to confirm that they have one of those symptoms.
So how do you know that 25% of people actually have registered for the test but have no symptoms?
Because we've been running some surveys outside of our testing site. So after you've registered and you've then turned up at the testing site, and we've asked people whether or not they do actually have symptoms. And we surveyed, so if I give you the details, 24,000 people at 25 regional and local testing sites between the 1st and the 4th of September. The Secretary of State referred to this earlier today, and this data will be published online. 27% of people said they were there because they'd been in contact with someone who had tested positive, but they didn't have symptoms themselves.
Okay. In order to be there and to have got to the test centre and to be allocated a test, they've had to declare that they've had symptoms. So you're saying 27% of people lied?
Well, I completely understand why people are worried and scared and coming forward for tests.
That is what you're saying, that 27% of people lied about their symptoms.
No, I'm not. But our local testing sites, you don't need to make a booking. You can just walk up. So some people will just be walking up to get a test because they're worried, because a colleague or a family member has tested positive, and it's totally understandable.
They wouldn't be allocated a test. They'd be advised that they needed symptoms to have a test, would they not?
They ought to have symptoms.
So that's not a demand on the test. They're not using tests. They wouldn't have been given the tests in those circumstances.
Generally, if we have people walking up, having either booked a test or asking for one, are brilliant people who are manning the hundreds of testing sites across the country, don't want to push away people who are scared. But we do have a significant number of people who are coming forward for tests who don't have symptoms.
Why have we had this sudden increase in demand? I think you'd agree that there has been an increase in demand, I assume.
Yes, there has definitely been a substantial increase in demand. I think that Professor Hannigan and the previous witnesses in your earlier session referred to some of this, which is that it's an entirely human thing to be scared and worried and to then think that the answer is to get a test. And so, if I, again, give you some examples, a restaurant owner contacted me yesterday where one of their staff had tested positive, and they then asked all of the staff to go and get tested. Whereas actually, unless they had symptoms, they really didn't need to be tested.
That could happen at any time. There's no reason why September has seen this increase in demand.
I think we, again, as Professor Hannigan pointed to, I think with all of our children going back to school, we've seen a very marked increase in the number of young children coming forward to be tested. So a doubling of the number of children under 17 coming forward to be tested, and more than that in the ages of 5 to 9. And again, I think, as I say, I completely understand this. I've got children at school myself. The temptation is one of your children has a temperature, they need a test, but then the rest of the family gets tested as well.
We knew the children were going back to school in September, did we not? It didn't come as a surprise.
And we planned for a sizable increase in testing capacity. As I've just described, we've been adding testing capacity every day, every week, over the course of the last few weeks, in anticipation.
But not enough.
Well, plainly,
by a multiple factors.
As the Prime Minister said yesterday, plainly we don't have enough testing capacity today, and we are doing everything in our power to increase the testing capacity.
One of the reflections this committee has made, and our purpose in conducting these inquiries, is to learn lessons that can be useful for decisions further down the road. And in the early days of testing, lots of decisions had to be made very quickly, and it's understandable that not all of those were the right ones, and there's no particular blame that can always be attached to that. But we did establish, I think, a consensus that we ought to have anticipated the need for increased testing and to put that in place before the Secretary of State made his personal commitment to surge it during April. And so it's dispiriting to find that we're now in September in circumstances which are entirely predictable, that people are going back to school, people are going back to work, and we haven't had the right capacity put in place during the quieter times of, say, June, July and August. Why didn't that happen?
Well, actually, I don't think that's true. So at the end of May, we had 128,000 tests a day capacity. Today we have 242,000. So it's not been a quiet summer for NHS Test and Trace at all. We've doubled the size of our testing capacity, which is exactly what we committed to do. And we're on track to double it again to 500,000 tests a day by the end of October.
During the month of April, the Secretary of State increased testing from 1,000 a day to 100,000 a day, a 100-fold increase. What seems to be apparent is that you haven't prepared for the increase in demand that has transpired. It may have doubled, it may have increased, but it hasn't surged to the extent that was done before, and clearly ought to have been done for September. Why wasn't that the case?
Well, as I said, as the Prime Minister said yesterday, plainly we do need to expand testing capacity. And I really understand the frustration and worry that people have who are trying to come forward for tests.
Is there a problem with the assessment of demand? Are we going to be able to have accurate predictions or assessments of what demand will be in the future.
Could I just answer the previous question? So we built our testing capacity plans based on SAGE modelling. We published our business plan at the end of July, and we are absolutely on track to deliver that. So we're doing everything in our power to bring that forward. But we will have, and I would say that today we have more tests per 100,000 population than any other major country in Europe. We have in total tested more people per million population than any other country that has been hit badly by COVID other than Israel.
I do understand that, and so you've made a very important point. So the capacity that you have created has been the capacity that SAGE told you was needed at this stage?
Yes, we built our capacity plans based on SAGE modelling for what we should be preparing for the autumn.
That assessment was SAGE's rather than NHS Test and Trace?
Yes, indeed.
Okay. So the capacity is going to be increased to 500,000 a day, we understand from the Prime Minister.
Yes, that's correct. By the end of October, we will be able to offer 500,000 tests a day.
Will that be enough?
Well, I am certain that we will need more as we go beyond the end of October. And we announced this morning 2 further laboratories that will be opening, one in Newcastle, one in Berkshire. Those laboratories won't be on stream by the end of October. So we are already laying the foundations for expanding capacity beyond the 500,000 at the end of October.
You must have made an assessment, it would be necessary to make an assessment as to whether the 500,000, insofar as you can project it, have you set that because that's what you expect demand to be by the end of October?
We've set it as those were our plans, but as I said, Chair, it's clear from today that demand is significantly outstripping the capacity that we have. And so we are all going to need to work on this together. We do need to make sure that we protect the testing capacity we have for the people that most need it, which means that people who have symptoms are the people who should be coming forward to be tested.
Just in terms of that future demand and the future capacity, now we know from scientists on SAGE that the number of people in the population that display COVID-like symptoms during an ordinary winter, when COVID is not present, is 500,000 a day. So the capacity that you'll have by the end of October is only enough for the coughs and colds that people have normally. It actually doesn't address the extra demand that comes from a pandemic and perhaps the extra concerns and sensitivity that people have that they may notice symptoms more if they know that COVID is around. Well,
and as I said, we have plans to go beyond the 500,000 a day, and we announced openings of new labs today that will contribute to that. And our work on capacity building beyond the end of October is based on, again, clinical and scientific modelling of what the country should need in a winter season rather than a summer season.
I see. Go to Dawn and then to Mark.
Can I just come in on one vital point on this? How do you measure total capacity? Because the Prime Minister has said that there was a 375,000 capacity. You've now told the committee today that there's a 242,817 capacity. That seems to be a reduction in the capacity that the Prime Minister said. But how do you measure the capacity, and do you need to revise how it is assessed?
The figures I've quoted you are antigen testing. The figures the Prime Minister was quoting are combined antigen and antibody testing, so they're completely consistent.
Right, so it's 2 different.
Clearly you didn't prepare enough for the schools coming back and people going back to work. The fact that the end of October was the target date to have this capacity in place, was that because you expected a second wave, as it's sometimes called, to be in October? Has it come earlier than you expected? Is that the problem?
Well, I think that I don't think anybody was expecting to see the really sizable increase in demand that we've seen over the course of the last few weeks. So none of the modelling was that expected. And that's why I say I think we all have to think really hard about how we prioritise the use of these tests. That we're clear that you should only get tested if you have the coronavirus symptoms, if you've got a fever, that you've got a new and persistent cough, or that you've lost your sense of taste and smell. And so we're all going to have to play our part in managing the constrained capacity, even as we double it and keep going beyond that.
That's been the guidance for months now. The rationing is within people that have symptoms, that certain people with symptoms won't be able to access it for the time being.
As I said, we see quite a lot of people coming forward who don't have symptoms, who and I really understand why you would feel like this, who want to believe that if they get a test, they won't need to self-isolate, that if one of their family members has tested positive, that if they get a test, they won't have to isolate with them. And sadly, that isn't how the virus works, and it isn't the medical guidance.
If you strip that out, you still don't have enough capacity. The Secretary of State this morning said that people would need to be prioritised amongst those that have symptoms.
Yes, and we're very clear on our prioritisation. So, firstly, we're prioritising support for NHS clinical care, NHS patients. So we test hospital patients, including all admissions. That's the number one priority. Well, our number two priority, and again, Professor Hannigan referred to this, is to protect those in care homes. This is the one group of people who we're testing who don't have symptoms. We know that the best way we can protect those of us, our loved ones living in our care homes, is to make sure that we regularly test care home workers and residents and all new admissions into care homes. So of our testing capacity, roughly 50% of our testing capacity goes towards NHS clinical care and testing in social care. And that's before we...
So hospital patients, social care, what's the next priority?
NHS staff, including GPs and pharmacists where possible. Mm-hmm. That's the third priority. And actually, sorry, I misquoted. Let me get that right. The three priorities of NHS patients, social care, and then NHS staff make up about 50% of the total testing capacity today. And then below that, once we move to testing the general public, community testing, we are prioritising additional testing capacity for outbreak areas. So we look to make more mobile testing units, to have more tests in local testing sites for areas with very high disease prevalence. And then finally, the broad general public, where we are looking now, given the very large demand, to prioritise within that key workers, particularly teachers.
Is there a hierarchy within key workers?
Well, as I say, we're just currently working on that. But as many people have said, prioritising education and particularly teachers so that schools can remain functioning would be likely to be top of that list. The work is still ongoing.
I'll turn to Mark Logan now, but just to be clear, so 50% of the capacity you expect to be taken up by NHS patients, NHS workers, social care workers.
As of today, that is 50%.
The remaining 50%, first of all, will go to outbreak areas. As of today, what proportion do you expect to be consumed by that?
Well, if I could answer the question slightly differently, on average, across the country, we are testing in each local authority at a level of roughly 100 people per 100,000. Mm-hmm. And in our outbreak areas, we are testing at roughly 2 to 3 times that level. That's the way we look at it.
That remaining 50%,
yeah.
What proportion of that 50% will be mopped up by the outbreak areas?
I haven't got that figure in my head. I'm really sorry, because the number of outbreak areas changes from day to day and week to week. So I can share that with the committee.
This evening when you get back, I can let the committee know that, and therefore what the residual is for the other key workers.
And I should there is one other element of testing that runs underneath this, which again your previous witnesses mentioned, which is the programmes we have, the surveillance programmes we have, the research programmes to make sure that we understand the prevalence of the disease, the ONS and REACT surveys.
That's not useful in isolating and treating.
No, but it is using testing capacity, and it's important that it does.